You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
As of today, the ravages of COVID-19 continue in America. Deaths from the coronavirus make up a full 1/4 of all the mortality due to COVID-19 around the globe. This in the wealthiest, most advanced country in the world that is home to what is often referred to as the best medicine and healthcare to be had, albeit at the highest cost of any other country. Among 13 highly developed societies, the United States ranks last in infant morbidity, much of which is attributable to the high number of babies of Black women whose infants die within the first year of life. Moreover, while maternal morbidity has declined across the globe, America is the only developed society where the rate of mothers dying in childbirth is actually rising. At the outset of COVID-19, the leadership of the American scientific and healthcare sectors found themselves at odds with political and government leaders who offered and malinformed advice to the American people about how to remain well and avoid catching the virus. No one knows how many of the more than 200,000 lives lost to COVID died unnecessarily and prematurely as a result of following incorrect guidance. For American higher education, COVID has posed two major questions. First, how are universities and colleges, medical and other health professional schools supposed to carry out their missions of preparing the next generation of nurses, physicians, public health professionals, technicians in the midst of a pandemic for which there is still no vaccine? And second, are the universities and colleges supposed to continue preparing healthcare professionals using the same formats and protocols, pedagogies, and assessment tools as were applied before COVID-19? Or has the virus exposed shortcomings in how we prepare graduates, shortcomings that need to be identified and remedied? Answers to those two questions seem tentative. Already, several universities have announced their plans for beginning a new academic year in traditional ways, only to change course in the space of a few weeks. And answers to the second question, are we preparing health professionals in the right ways to enable them to be effective givers of care, are not heard so much, save for the seemingly shared conviction that we need many, many more health professionals than are and will be available soon. The old joke about the drunk under the streetlight on a corner, obviously searching for something on the ground under the lamppost, seems appropriate to hearken back to at this point. Asked by a passerby whether he had lost something there, the drunk replied, "No, but the light's better here." Answer to those two questions may not be easily answered, but at least by talking with our guests, she will undoubtedly shed light on them both. Bernadette Melnyk has multiple duties at The Ohio State University. She is a professor and the dean of the College of Nursing, but her responsibilities do not end there. She is the vice president for health promotion and the chief wellness officer for the entire university. In her ample spare time, she is also the executive director of the Institute for Evidencebased Practice in Nursing and Healthcare of the Helene Fold Health Foundation. When some people excel professionally, the drive of personal experience and not material gain or even personal acclaim is what motivates them. As a teenager, Dr. Melnyk's mother died before her daughter's eyes, leaving her to find her way in the world. In rural Pennsylvania, where she lived, there was little to comfort the 15-year-old, so she had to deal with the grief and trauma and find her own way, and she did. Dr. Melnyk earned a nursing degree from West Virginia University and went to work at Children's Hospital in Pittsburgh. She then earned a master's as a pediatric nurse practitioner from the University of Pittsburgh and then a PhD from the University of Rochester. After her PhD, she also obtained her education and certification as a psychiatric mental health nurse practitioner. That's an impressive recovery from personal tragedy, and that might have been enough for most people. But that tragedy motivated Dr. Melnyk to go further and develop programs for children, teenagers, and young adults to relieve them of the stress and mental illness that afflicts young women and men, including 15-year-olds who love their mother. Welcome to Innovators, Dr. Melnyk. As you look back since February of this year, when the coronavirus really came full bore to the United States, what strikes you most about its impact on America?
The mental health effects in America with COVID-19 right now are just soaring. We had what I call a mental health, public health epidemic prior to COVID-19. We are going to see rates of depression, anxiety, suicide, post-traumatic stress, unlike anything we have ever seen before. And it's hitting our young people especially hard right now.
Do you have a sense of what it is about this disease that creates that kind of environment? Is there any precedent?
I think we have multiple issues going on. The media and too much media exposure is contributing to so much fear, anxiety, and depression in people. Then put on top of that loneliness from physical distancing. Young people, particularly in college, they had issues, believe it or not, with loneliness prior to COVID-19. If you walked a college campus prior to COVID, what do you see? What did we see? It was students walking on campus with earbuds and their iPhones, texting while they walk, sitting down to have meals together on their iPhones. Now put quarantine, isolation on top of that. The loneliness is contributing to a lot of depression too.
Early spring, when COVID-19 really came into effect, we've been asking experts such as you, including people in public health, medicine, and the like, whether some of the problems of COVID-19 for the United States was because we have a system, a federal system of government, in which the primary responsibility for public health rests with states and local governments, and the role of the federal government is kind of hard to figure out exactly what it's supposed to be. Given a system like that, could we have realistically expected to get what we've seen, which is a great deal of confusion, a great deal of broken links, shall we say? Is it time that we look differently at this system of public health?
I think we have to look at our current U.S. healthcare system very differently. We need solutions to what is occurring right now. We spend more money on healthcare than any Western world country, but we rank 37th in health outcomes. We must change our paradigm from sick care to well care. 80% of chronic disease and that includes mental health disorders. 80% is preventable with just a few healthy lifestyle behaviors. Physical activity, 30 minutes, 5 days a week. 5 fruits and vegetables a day. Don't smoke. And if you drink alcohol, which by the way, is on the rise with COVID. If you drink alcohol, limit it to 1 drink a day for both men and women. We have a lack of coordination too that's going on. We have media from different stations giving their perspectives in totally different ways. That's confusing the American public. Communication is so key. Not enough leads to people having uncertainty, not knowing for sure what's best evidence. Having too much media focused on just all the adverse outcomes instills so much fear in people. So I tell people, limit your media exposure right now.
So this is important because I think you're the first person who has been very clear that there is such a thing as too much information, especially when we're working in an environment in which there are mixed messages, to say the least.
Right. Plus, the data is changing, right? In terms of treatments, you have studies coming out saying hydroxychloroquine led to good outcomes. You have other studies coming out saying that's not the case. And the public often doesn't know how to critically appraise evidence. And that's why we've got to make sure our top public health officials are communicating that evidence to people very clearly in ways that they can understand. Because data is empowering for people, and people need best evidence so they can advocate for themselves and their family members.
If I follow the train of that, if in the beginning we had been very clear that we don't know that as much about this virus as we probably, as clearly as much as we need, but there was at the time a notion that there were some fairly quick fixes to this. I remember that very clearly, that we can do this and we can do this and that'll stop the problem. We now see that even countries that apparently did a wonderful job in dealing with it, New Zealand, for example, are now back struggling. Is there some role for a little less hubris, a little more modest sense of what we're capable of doing with our medical and healthcare system that might have avoided some of what we're talking about here, which is there's a way to fix this and it's right before us and that'll do it. But in point of fact, as best I can tell, we're still learning about COVID-19. Am I right?
Absolutely. The evidence is changing on a daily basis. But again, I believe in transparency and clear coordination of communication. And I think that's been a character builder right now. People are hearing different messaging, different evidence from a variety of people. So again, they're saying, I don't know for sure what to believe. So this coordination in communication is a big problem that I think our leaders need to fix.
You've been a nurse in a hospital and you've got friends who are in public health and the like. These last 20 years have not been kind to those folks. I can remember when the Great Recession set in 2009, 2010. Governments and local governments at that point, most of their tax base had eroded away very quickly. And so they had to make cuts. And it seemed as though it was almost easier to make cuts in public health. So I can remember in certain parts of the country where I had lived at some point or another, that you would find out that local health department had 2 people, and one person was just to answer the phones, and that's all. Are we at a point now where that human infrastructure simply can't do more than barely get by? I mean, it just seems to me there's a real struggle now, as much with the human infrastructure for coping with this disease as anything else. Is that too harsh a judgment?
I don't think so. Interestingly, I meet with legislators periodically to talk about some solutions. How do we fix a broken healthcare system? One legislator said to me not too long ago, Bern, don't tell me we need more money devoted to this. We're not going to have more money. So what do you propose? What's your solution? I said, I'll give you a solution. Let's stop funding. Let's de-implement non-evidence-based programs and more quickly translate things that we know work into the real world settings. That's what we have to do. Because, Rick, we know when people receive evidence-based healthcare and the public's under the perception, don't all healthcare providers, don't all healthcare systems deliver evidence-based healthcare? No, they don't. There's a lot of things that continue to be funded and implemented because that's the way we've always done it. Or this is a pet program of a certain legislator. So they don't want to see it defunded. But if we could get every clinician, every hospital and healthcare system throughout the United States to deliver consistently evidence-based healthcare, our outcomes would be so much better.
And the data for that is not hard to find.
Not at all.
If you do all the studies, it shows that.
We know evidence-based healthcare will help us to reach the quadruple aim in healthcare. It will. But again, you still have so many colleges throughout the country who teach health profession students that they're not preparing them to meet evidence-based practice competency. Every graduate of a health profession school should be competent in evidence-based practice by the time they get out. And then our healthcare systems need to create cultures where evidence-based practice is the default. It's the norm in the system.
I want to come back to this because I think one of the questions I have is, what's the steps to make these happen? So I want to come back there, but let me turn to an issue that I happen to know is pretty close to you. For somebody like me, the past 6 months have been consumed not just by COVID-19 and an economy that's bordering on a depression, but also by the profound disparities among racial, ethnic, and income groups in America. Stated simply, in America, if you are a person of color, already suffering from a chronic disease, such as obesity, depression, or high blood pressure, you are much more likely than any other economic or demographic group to come down with the disease, struggle to survive, but ultimately succumb. Now, the stark nature of that simply serves to confirm for some the argument that racism, xenophobia, poverty are systematic, not random features of the American society. Now, you have a personal and a professional concern for these patterns because it focuses in some ways on something I know that is near and dear to your heart, is that is mental health, especially for children and adolescents and young adults. So what if the circumstances of COVID-19, an economy in free fall, and known but still not really addressed disparities among different groups of Americans, what is it revealed to us, and what can and should be done to deal more forthrightly, especially with mental illness?
We were into a serious public health epidemic with mental health problems before COVID. It's escalating much more now. In fact, a latest study by the Kaiser Family Foundation conducted this past spring identified that a third of Americans are suffering from a mental health problem right now.
A third?
A third. Now, take our college students. Even before the pandemic, 36% of them were suffering from depression, 31% suffering from anxiety disorder. And in a 2019 survey by the American College Health Association, 56% of students in 2019 said they felt things were hopeless. 56%. That was before the pandemic hit. Can you imagine now? A recent study also showed 11% of people have thought about suicide since COVID. In our young adults 18 to 24, 25% have thought about suicide. Suicide was the second leading cause of death in 10-year-olds to 34-year-olds prior to the pandemic. What is it going to be now as people are feeling so much stress, anxiety, and depression? The people who are going to fare better through this whole pandemic are the ones that have built resiliency and coping skills. We, as a system, as a country, again, have been focused on crisis intervention for mental health disorders versus let's make sure our children, our teenagers, our college students get evidence-based cognitive behavioral skills building, mindfulness training. That's a protective buffer against stress, anxiety, and depression. And we have programs that we know work. So we should be blitzing the country right now with those programs. We would never send a construction worker into a work site without a hard hat. How can we send our children and young people throughout life without giving them these skills that we know are protective against depression and anxiety?
And I think you've answered a question that I posed in an introduction. I think for many in higher education, much time and effort has been given to saying, how do we open for the school year? And as recently as yesterday, we saw that one of our major great universities, having committed to one form of opening, had to change its mind and start back over again. So we're still struggling with that issue. But on top of that, there's another one, and that is all of the health professions. Are they at a point now where we can continue to deliver those programs and the content and the experience of those programs in such a way that will actually change the paradigm that you described. Let me be specific. A nurse, the way a nurse is prepared now, are we actually seeing change in that? And is that change in a direction that is likely to promote wellness as opposed to saying, how do you deal with a health crisis?
I can assure you, we have switched the paradigm at Ohio State. Our students are getting steeped in wellness, prevention, protective factors. How do you develop those in communities, in groups, in individuals? Again, we tend to move to short-term instead of long-term preventive thinking, because people want to see return on investment, right? For what we do. The return on investment for wellness and prevention, like we've shown at Ohio State, is excellent. For every dollar we put in the wellness, we get $3.65 back. Executives need to see that return on investment. People don't realize, and we have so much evidence to show this, if people are mentally and physically well, they're more engaged. Their productivity is higher. There's less presenteeism, less absenteeism. Our children, our teens, our college students have higher academic performance when they're mentally and physically well. We need to invest in that type of wellness.
I can't help but think that, and I'm sure you've had this experience of having someone who you decided you're going to invest money for your retirement, who points out that if all you do is respond to the market day in and day out, you're not likely going to have good returns. Whereas if you could develop a plan that says, I'm in this for the long haul, then the reality is you're probably going to be fine. But what I hear you saying is we've been thinking about the quick fixes. We've been thinking about the short-term returns. And as a result, we're spending more money, but we're not getting more for it.
That's correct.
So that, I guess that leads me in a way to talk about something that's kind of near and dear to our firm's heart. After we began, about a year ago, looking at the whole field of health professions and public health, we went through a series of discussions with people such as yourself, people who are experts in the field, and we kept asking them, what's needed, especially on university campus now. You're at a university that has over 50,000 students. You've got research going on probably in excess of $3 billion. You run a hospital. I mean, all of those things. It's an incredibly complex environment. And when you ask who's in charge of all this, there's a kind of answer that says, well, there's this and then there's this. Similarly, when we saw that COVID was coming, we immediately set a task force together and they said, okay, who does this person who's going to be the point person? And the answer was that took another committee just to decide that. So we've not been reluctant at all to make the argument that universities, especially research intensive universities, need to invest in something we call the chief health officer. And it wasn't just a reaction to the COVID-19, it was the fact that universities had become so complex, so multifaceted. In some respects, a small city, but a small city on a ship in waters that were not necessarily friendly. You're a chief wellness officer. Are those two things different, number one? And two, if they are, help us to make the case for one or the other so that we can help universities get through not just COVID-19, but what are going to be choppy waters and difficult times for some time to come. Help us to make that case.
Rick, I'm so glad you asked me that question. And I don't know if you know the history on how I got to Ohio State, but I actually pitched the dream of being the first chief wellness officer at a university in the country.
I should have known that.
When Ohio State was calling me to convince me to throw my hat in the ring for the dean of nursing position. And I said, I'm humbled that you thought of me, but I don't want to make a lateral move. However, if there were an opportunity to combine the dean's job with a university-wide leadership role as a chief wellness officer, I might talk to you all. The next thing,
tough nut to crack then.
The next thing, Gordon Gee, president of Ohio State at the time, he calls me, Melnyk, what's this hype about a chief wellness officer that you're talking about? And what would you do for us if you came into that role? So I came to Ohio State. I met with Gordon in the leadership. I provided evidence on why universities need to invest more in wellness of their faculty, staff, and students. That's how I got to Ohio State. And I'm so excited to tell you, again, our return on investment has been outstanding. We truly have a culture of well-being that makes healthy behaviors the default choice for our people. Health promotion, well-being is critical. A lot of people intertwine chief wellness officer with chief health officer. They're basically the same. I like wellness better. And in fact, I'm serving on the National Academy of Medicine's Action Collaborative on clinician well-being. And we wrote a health affairs blog that was all about making the case for chief wellness officers in America. I'm happy to tell you, since we published that blog, and I've published other articles on the success that we've had here at Ohio State, more universities and healthcare systems are hiring chief wellness officers right now. And that's great. Kudos to all those institutions doing that.
Then I have to close with one more question then. If you were starting from scratch now to be a chief wellness officer or to advise a university that's thinking about it, what are one or two things that you would say to them, if you don't do this, then don't bother? What are the essential elements that have made it possible for you at Ohio State, a large, complex institution? What has made it possible for you to not only get a return on investment, but be able to measure it?
A couple of important key elements. Give that chief wellness officer a team of people to work with. You don't have to spend huge amounts of dollars, but a even small team that has an exciting vision. And another key piece, you've got to catch this dream for where you want to be and what you want to accomplish and have a strategic plan with outcome measures that you're going to track religiously over time. And then there's a real secret of success that a lot of people don't realize that's not expensive at all. You establish a critical mass of faculty, staff and students as wellness champions, or we call ours Buckeye Wellness Innovators. I have 700 of them throughout the university that works with me and my team to create cultures of wellness across every college, hospital that we have. And these people volunteer their time. So that's where it doesn't cost much, but they are a force in the grassroots that makes such a difference.
Well, you need to add one fourth factor that's critical, and that's to clone you for every campus that wants to do this. If we can just
they do.
Work on that. Can you work on that for me, please?
They do call.
Well, I'm not surprised. After this, we'll have more calls. Let me offer you something just as an old guy who has been around higher education a long time. It's rare these days someone involved in the administration of higher education who has a sense of urgency, but the urgency is not necessarily out of fear. It's out of hope and an expectation that things can be done. You alone are one of those voices, and I want to thank you very much for that, as well as your time today with us on Innovators. Thank you again. We hope to talk to you soon in the future.
Thank you for covering these so critical concepts.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.